Welcome to The Hair Loss Show. Dr. Russell Knudsen and Dr. Vikram Jayaprakash discuss issues relating to hair loss and the medical and surgical treatment of hair loss in both men and women.
Hi everyone, my name is Dr. Vikram Jayaprakash and welcome to the Hair Loss Show. No episode number today, I'm flying solo because this is a video I thought we just we'll call it like an in-between-isode, and I just thought I'd do it on my own because it doesn't really fit in with what exactly Russell and I want to the message we're trying to convey and what we're trying to, the content that we're trying to promote. But I'd been getting enough questions on the channel, and thank you very much for the questions. Please do keep them coming, that I thought it'd be worthwhile just quickly doing this video specifically on testosterone, finasteride, DHT, and biochemistry. We get a lot of questions on that and the impact of all of those things, and estrogen as well. So this is just a quick video on that topic. Now I want to preface this by saying that this is not something that I talk about regularly with my patients. So it doesn't fit into my normal consultation process because I think that's probably lies out of the sphere of what we're trying to achieve within a consultation. But I think there was enough of you that asked the question and I thought, well, okay, let's have a chat about it and go from there. So here goes. So the first thing, I mean, this is in the essence of trying to keep lower the amount of time it takes, I've drawn out the biochemical process. This is how hormones, steroid hormones, are created in the body. Okay, and as you can see from here, hopefully you can see, cholesterol is the starting point. So all steroid hormones are made from cholesterol. And cholesterol gets a bad rep. Everyone's on statins to try and lower cholesterol. But you need cholesterol to start this process. Cholesterol, you need something for, it converts into pregnenolone. Pregnenolone is really important for the brain. Pregnenolone is also called the mother hormone. It converts to progesterone, which converts to aldosterone, important for kidney function. Pregnenolone, converts into 17-hydroxypregnenolone, which then converts into cortisol. Cortisol, an adrenal hormone, probably one of the most important hormones in your body. You cannot live, it's a stress-related hormone, you cannot live without cortisol. So you can see all these things, really important that you have cholesterol in order to make. Think of this as the recipe guide in how you make these things. 17-hydroxyprogesterone converts into DHEA. A lot of you heard about DHEA. DHEA stands for dihydroepiandrosterone. You don't need to remember that. But the important thing, DHEA converts androstenedione into this thing, testosterone. Okay, now testosterone is a fantastic hormone. It is useful and it's vitally important both in men as well as women. Women just don't need as much as men. And a lot of people think that testosterone is just about, building muscle or for libido and sex drive. And it's not the case. It has those functions, but it also, we know that it is of prime importance for protecting the heart. So people that have low levels of testosterone have increased risk of heart disease. It protects the brain. We know that people that have low testosterone have an increased risk of strokes and cerebrovascular accidents. We also know that also Alzheimer's. They've done studies where they've looked at populations with Alzheimer's and without Alzheimer's. The population that have Alzheimer's generally have lower levels of testosterone. Testosterone is linked to prostate cancer. So men with prostate cancer generally have lower levels of testosterone. And we've also found that low levels of testosterone are associated with depression as well. So yes, testosterone is of vital importance. But if we go back to the board, testosterone, and this is the bit that I normally focus on. in a consultation. I don't talk about any of this. This is the bit that I talk about, and we've talked about in previous episodes as well. Testosterone converts into dihydrotestosterone, or DHT. Now, DHT is really important. We've talked about this before. It's important, certainly, as you're going through puberty. It's important with the generation of all the sex organs and going through puberty. So DHT is important. But testosterone converts to DHT with this enzyme called the 5-alpha reductase enzyme. And if you convert that and you have the gene for hair loss, okay, so you need the gene as well. If you've got the gene for hair loss and you've got high levels of DHT, that can cause miniaturization of hair and result in male pattern hair loss. All right, so that's where we focus on when I'm speaking to patients and doing consultations with patients. So 5-alpha reductase enzyme is important, and we use a medicine called Finasteride. There's also Dihydrotestosterone as well. So there's Fin and Dihydrotestosterone. It blocks that enzyme. If you block the enzyme, you block the conversion of that to that, and you lower the DHT in the system. All right. Coming back to the biochemistry of things, because testosterone also converts into estradiol, or estrogen. Estrogen is important, okay? Men need estrogen as well. We don't need a lot of it, but we need some estrogen. It's important for brain function. And also, it's important for bone health, all right? So we need good, adequate amounts of estrogen. And there is an enzyme called the aromatase enzyme, and that converts estrogen into estradiol. And there's a medication, and I don't want to go too much into it, called Arimidex. And Arimidex blocks that enzyme. You block the enzyme, you block the conversion of testosterone into estrogen. All right? So that's a simplicity. I mean, that is effectively the biochemical pathway. All right. So, but I mean, that's not all of it as well, because, you know, we talk about how this is produced, but there's another pathway which I haven't drawn, which is about how that is controlled, how the production of testosterone is controlled. And so what we do real quick, we've got the hypothalamus here. Now, the hypothalamus is in the brain, and it's constantly checking levels. And it will check the levels of not estrogen, but the estrogen receptor. So estrogen is a hormone. It binds to a receptor. So it will check that the amount of that estrogen receptor that is bound to estrogen. So if you've got enough testosterone, you're going to convert a bit to estradiol, or estrogen, for sake of this discussion, and you will have high amounts of the compound of the receptor and the enzyme. But if you have low testosterone, you will get low amounts of the estrogen receptor estrogen complex. And if the body detects low amounts of the estrogen receptor complex, what it will do is it will send a message over to the pituitary gland. Okay, and it will release something. I don't want to get caught up in this, but it will release something called Gonadotropin-Releasing Hormone. All right, don't worry too much about it. But it will stimulate the pituitary gland, okay? And then the pituitary, what it will do is it will stimulate the testicles, all right, through two different signaling pathways. One signaling pathway is FSH, and one is called LH. LH is from the Leydig cells, FSH from the Sertoli cells, and it will increase sperm. Basically, it stimulates the testicles, and the testicles will stimulate will produce more testosterone, and that will increase the testosterone floating around in the bloodstream. There's a feedback mechanism. So what happens is you've got more testosterone, then the testosterone converts into estrogen. The estrogen combines to the estrogen receptor complex, and what happens is then you've got normal amounts, and that has a negative feedback on the hypothalamus, and therefore that stops that cycle from happening. All right. So I hope that explains what's going on there. So So let's put that into perspective, or certainly in terms of where the questions came in. So when we're talking about hair, and we're talking about finasteride and dutasteride as well. So people are asking, well, you know, one of the common questions that I get is, does taking finasteride lower levels of testosterone? Well, no, because if you're taking finasteride, you're blocking the conversion of testosterone into DHT. If you're blocking that, then you're going to leave more testosterone. So in essence, the answer is no. It doesn't reduce the amount of testosterone in the bloodstream or in the body. But will it increase the level? Because, you know, arguably, if you're blocking that and not converting that into that, then you should be increasing that. And technically speaking, if you're looking at that diagram, then the answer is yes. But it's not so simple. Because there's that negative feedback, but more importantly, is that if we're talking about using finasteride for hair loss, we're talking about small doses. All right, we're not talking about using it in the dose that we would use for, say, someone with prostate issues, which is a 5 milligram tablet per day. We're talking about 1 milligram 3 times a week. So we're not talking about 35 milligrams per week, we're talking about 3 milligrams per week. At that low dose, it's not really going to change the amount of testosterone that you've got running around the system. All right? And that brings me to, my apologies for moving around a little bit, but that brings me to, well, what do we talk about when we're talking about testosterone? Okay? Because testosterone, it's not just this one thing, testosterone. Testosterone exists in multiple different forms. So testosterone exists in a free form, okay? When it's free, then it does everything that we talked about. It, you know, helps, boost muscle growth. It helps, you know, the heart, the brain, all that sort of stuff. So free testosterone is the only bit that can do that. Okay, testosterone also exists in other forms. It can be bound to something called sex hormone binding globulin, or SHBG. It can be bound to, and once it's bound to that, that's it. You can't use the testosterone anymore. But you can. It's also bound to albumin as well, which also makes it relatively inert. So, you know, just looking at when you do a blood test, for example, and you measure the total testosterone, it doesn't give you an accurate idea of how much your testosterone is, because realistically it's the free testosterone that's important. And in order to calculate that, you need to know the albumin, you need to know what the level of SHBG as well. So, but going back to my point, finasteride or dutasteride, if you take it in the doses that we're talking about, you're not only trying to reduce this level of DHT below a threshold level. You're not trying to bring it down to zero. We don't need to do that. We just need to bring it below the threshold that results in miniaturization of hair. All right? And that will vary from person to person, but we found that 3 milligrams per week is kind of like the sweet spot where that happens. So no, it doesn't. It certainly doesn't lower the level of testosterone. Does it increase the level of testosterone? Well, I've seen studies where what they've done is they've taken guys with low levels of testosterone, and then they've given them testosterone, and they've given them finasteride, and they had higher grip strength. But the fallacy there, okay, is that they gave them 5 milligrams of finasteride a day, massive doses. So if you're giving them more testosterone and you're blocking this, then yes, you're going to increase the testosterone, and by consequence, you're going to get, you know, the increased muscle hypertrophy. One of the other questions that we get, I normally don't take notes, but I thought I'd write down the list of the questions that we commonly get asked, so I don't want to forget any of them. So the next question is, if you're on finasteride, should you be on Arimidex? All right. And I think this is, you know, there are a lot of people, and they taking a lot of this to heart and being, you know, focusing on that. And again, it comes to the point where, are you measuring the right thing? Are you measuring free testosterone? But the principle there of that question is, well, if you're blocking this, all right, in theory, you have more testosterone. If you have more testosterone, are you driving the equation more to this side? Are you going to be producing more estrogen? Now, like I said at the beginning of this episode, estrogen is really important, guys, but having too much estrogen is problematic and can cause issues. It can cause things like gynecomastia, but it can also cause prostate issues and prostate hypertrophy. So, yes, you don't want the estrogen to go sky high, all right? So again, it comes down to the dosing. All right. So if you're just taking a small dose of finasteride, I don't think you're going to increase the testosterone levels significantly. And so as part of our practice, both Russell's and myself, we don't give people, we don't give people finasteride and Arimidex to block the aromatase enzyme to try and keep it as testosterone. That's not the goal. The idea is just to focus on this. We just need to get that level below the threshold. So that's not part of our normal practice there. Next question. I hope that answers that question. Next question. Is there an increased risk of prostate cancer with finasteride? The answer is no, in essence, and they've studied that, and they've shown that that's not the case. Where proponents of that idea are, again, coming back to blocking that, increasing that level, and then subsequently increasing estrogen, which causes issues with the prostate. But if you're giving a small dose of finasteride, then generally the answer is no. That said, the other thing to be mindful of is that finasteride also lowers your PSA, your prostate surface antigen, which is a marker of, which is used to monitor people that have enlarged prostates. Okay? Now, generally, it is not used as a diagnostic tool. It should not be used, PSA should not be used as a diagnostic tool to measure the general population to see if they've got prostate cancer or not. That should be done, you see your doctor, you talk about your symptoms, you get examined properly, and then they check up, if you've got symptoms, the next thing to do is to check PSA. And the reason that's the case, just as a side note, is that there are lots of other things that can cause an elevated PSA. If I rode my bike here to work today, that would cause an increase in my PSA today. All right, so PSA, yes, is useful, but is a poor marker. But if you've already got an issue with your prostate, you've got an elevated PSA for whatever reason, associated with the prostate, then finasteride can artificially lower it. So you've got to be mindful of that. But again, in the dosing that we're talking about, we're not talking about 5 milligrams per day, we're talking about 1 milligram 3 times a week. It generally doesn't have too much of an impact. Okay? Next question. Does exogenous testosterone require the need to increase the dose of finasteride? Potentially. Okay, because if you're adding more of this, I say potentially because it depends on the individual. All right, if they have normal testosterone anyway, or they're hypogonadal, it just depends. If you're adding more testosterone there, then you're more likely to drive traffic down this way. So maybe you need a higher dose of finasteride to reduce the amount of DHT below that threshold level. That said, if you're taking exogenous testosterone, so if you're adding more testosterone here, then what you're going to do is you're going to promote that negative feedback, which is going to reduce your own production of testosterone anyway. And so what some people do, and I'm not advocating, is they're using drugs like Clomid, or selective estrogen receptor modulator drugs. Basically what that does is it blocks the estrogen receptor, and therefore the hypothalamus can't detect that. But in essence, adding more testosterone may require, a higher dose of finasteride. So that's taken on a case-by-case basis. So if I've got someone who is on exogenous testosterone, we will try them on a low dose and see how they go. I always, counsel patients saying that, look, hair loss is not a rapidly occurring phenomenon. It happens slowly. And so we can wait 3, 4, 6 months and see how things are progressing. And if we find that it's not moving as we want to, then we can adjust the dose appropriately. Okay, I think I've said enough there. Hopefully that answers those questions. And again, I just want to reiterate, this is not something that I think everyone who's suffering from hair loss should know. It's not. It's just that enough of you asked the question that I thought it'd probably be easier if I talked about it here, and then that will sort of give you another some pool of information for which to hopefully get educated on. But hopefully that makes sense. The take-home points are: testosterone, really important, okay? It's the conversion of testosterone to DHT that we're focusing on with hair loss. Generally, it's, we're just trying to get the level of DHT below that threshold level, and we generally don't need very much finasteride to do that. I've said finasteride, but, we can also use dutasteride. We can interchange that as well to block the 5-alpha reductase enzyme. So hopefully that answers those questions. Like I said, this is just a quick sort of episode in between everything else. Russell will be back, and we'll get back to our regular scheduled broadcasting soon. But I hope you find that useful. Thanks again for watching. Keep the comments coming. Please like the channel. Please subscribe, and we'll see you on the next episode. Thanks very much.